Hi again. This is a case with a quick teaching point. I think this would be useful for both seniors and juniors. I'll just go quickly over a few basic things so juniors could follow. Seniors, you'll see something interesting at the end. This is a CT scan of the chest without intravenous contrast on an adult male patient. This is anterior, this is posterior, this is right, and this is left. I'll give you a chance to look at the study. Now, so you understand the teaching points on the other case, I'll show a few normal anatomical structures on this other patient. So this other CT scan is done with intravenous contrast administration. You could see how the vessels are lighting up. This is the aorta, this is the pulmonary artery. One of the things that we commonly see are these small calcifications either in the hilum or in the mediastinum. For example, this soft tissue here, which is calcified, represents a small lymph node with a focal internal granuloma. Such granulomas are common. They're especially common in areas where a granulomatous exposure is common, such as TB or histoplasmosis. Another thing to keep an eye on would be the pulmonary arterial trunk, the right and left main pulmonary arteries. You could actually see the branches of the pulmonary arteries within the lungs. Of course, with contrast, this is much easier than looking at it without contrast, since you could differentiate an artery from an adjacent vein with ease. For example, this is a pulmonary artery that divides here, adjacent to a pulmonary vein which reaches all the way to the left atrium. Now, something else I want you to see would be the vessels in the neck here. Let's follow this from proximal to distal. This is the aortic arch, which gives you the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. On the right, the brachiocephalic artery divides into a right common carotid and right subclavian artery. On the left, you see the counterparts here. Now that you know this is the common carotid artery, it's easy to understand what this structure here is. This is the internal jugular vein, which runs parallel to the artery. The internal jugular vein on the right meets the subclavian vein on the right to form the brachiocephalic vein here. The same thing happens on the left where you have the brachiocephalic forming, and this is a brachiocephalic vein that contains a PICC line, a catheter. So both the vertically oriented right and horizontal left brachiocephalic vein meet together to form the SVC. To complete the picture, the SVC goes all the way down to drain into the right atrium, which opens into the right ventricle. And the right ventricle here pushes blood into the pulmonary trunk, subsequently into the main pulmonary arteries, and then into the lungs. One more small piece of information. This structure here draping anterior to the aorta and to the side is the thyroid gland. So don't confuse this thyroid gland with vessels, since it enhances significantly after contrast. Now back to the quiz case, and let's take it one by one. First, this is the thyroid gland and has these heterogeneous calcific densities. So these calcifications are partially or completely calcified thyroid gland nodules. Here I changed to a bone window, which shows calcifications in a better way. Now that we know that these are thyroid related, let's forget about them. And let's look at those here. What actually looks like calcific density is higher density and is metallic, circumferential, and well organized. Knowing our anatomy, you'll notice that this is involving the left internal jugular vein. There's another similar structure that involves the vein as well. And although difficult without intravenous contrast, knowing the anatomy, you'll also recognize that this here is involving the left subclavian vein. To appreciate those structures, let's look at this coronal image. So here's the involvement of the left internal jugular vein. This is the left subclavian vein. Looking at these densities carefully, you'll notice that they are not calcific, they're higher, they're metallic. And as we scroll back and forth, you'll notice that they have this organized appearance, this network kind of appearance. And they actually represent venous stents, likely due to venous stenosis. This is a stent in the left internal jugular vein, this is a stent in the left subclavian vein, and this is another one in the internal jugular vein. However, this portion of the stent here looks collapsed and potentially fractured. Now let's look at another thing. All those calcific densities are within vessels. This is within the aorta. These are within the coronary arteries. In addition to the atherosclerosis, the patient has this dense tram track-like appearance, which is related to coronary arterial stents. Now, the reason I'm showing the case is to look at this area here. So seniors, at a first glance, you might think that this high-density focus represents a hilar lymph node. However, that is not the case. Another thing that you might confuse this for is the aging calcifications in the cartilage of the airway, such as what you see here, or what you see here in the trachea or other segments of the left bronchus. And scrolling up and down, you'll notice that this is far away from the airway, so it's not related to cartilaginous calcifications. Despite the absence of intravenous contrast, you could follow this left pulmonary artery, and you'll notice that this here is continuous with a branch of the left pulmonary artery. And this segmental pulmonary arterial branch contains that high density area. Now if I switch to a bone window, you'll notice that this density is higher than calcium, it's metallic. You'll also notice that it has this kind of regular dot-like organized appearance. And thinking about it, this reminds us of the stents that we saw in the venous system above. Putting everything together, remember that potentially fractured left internal jugular venous stent. That part of the stent has actually fractured and embolized into the venous system, traveling in the left brachiocephalic vein, then the SVC, then the right atrium into the right ventricle, subsequently into the pulmonary artery, then the left main pulmonary artery, and finally being stuck and residing within a segmental branch of the left-sided pulmonary arterial circulation. So this is consistent with a non-thrombotic pulmonary arterial embolization of a stent fragment. And you could see that fragment within the pulmonary artery on this coronal image. Now, why did the patient have stents placed in stenosed left internal jugular and subclavian veins? You could complete the story by looking at the upper abdomen, where you have multiple bilateral renal cysts actually superimposed on thin renal parenchyma. Both features are consistent with long-standing chronic renal failure. So with that, you have thinning of the renal parenchyma and development of cysts over time. Since such patients require recurrent canalization of the vein for dialysis, they are at risk of developing stenosis. And this is what happened to this patient in his left internal jugular and left subclavian veins. So this is a case of chronic renal failure requiring multiple dialysis catheter insertion with subsequent stenosis of the left internal jugular and left subclavian veins, requiring venous stent placement, with one of the stents being fractured and embolizing all the way to a segmental pulmonary artery. So what did we learn today? For juniors, we reviewed the vascular anatomy. Even though it's difficult without IV contrast, now it's easier to understand. For seniors, not everything that's high density is a calcific lymph node. Make sure to exclude metallic densities. And remember, we have two types of pulmonary emboli, thrombotic, which is the common, and non-thrombotic, such as this case. Thanks for watching, and see you with more cases later. Hi again. Today's case is mainly dedicated for seniors. This is a diffusion-weighted MRI. And we're looking at the brain of a 40 years old female patient who presented with acute confusion. The diffusion-weighted image shows multiple small foci of high signal intensity. Although I'm not showing you the ADC map, all these lesions were restricted on diffusion. So we're looking at lesions that are acute. They're seen more at the brain convexity. You'll notice that these lesions are scattered in the brain convexity, and they're mainly at the periphery of the brain. This is high in the brain convexity with bright spots here. All the other spots are similar in distribution, involving the cortex. Even the smaller lesions are confined to the cortex, so you have multiple bilateral acute areas of restriction in the cortex. The patient also has this area that is dark, that is consistent with encephalomalacia, so dead tissue. And this is a chronic infarct that's not related to the recent attack. Now, when you have restricted diffusion acutely, the first thought would be that of an infarction. Infarct classically involves one vessel in a known vascular distribution, for example, an ACA or MCA distribution. What's unusual about this case is that multiple small foci of involvement are seen in different vascular distributions. Although the classic stroke that is seen in a vascular distribution is associated with atherosclerosis, however, a good subset of patients present with non-atherosclerotic embolic strokes. So these cardioembolic strokes are a result of emboli traveling from the heart or the neck vessels all the way to the brain. And whenever you see strokes in multiple distributions, you have to work up the patient to exclude a cardioembolic source. Now, the patient's echocardiogram was performed and it showed a normal study. There were no cardiac abnormalities. Things in the heart that you'd like to assess would include atrial fibrillation, thrombi, and a few other conditions. So there was no clear-cut cardiac embolic source. Now keep in mind the multiple tiny, patchy areas of predominantly cortical involvement. When you see something like this, in addition to the cardioembolic theory, you have to think about another condition. Before I go to that condition, let me show you the CT angiogram of the patient's brain. So this is a CT angiogram of the circle of Willis. I'll give you a chance to look at the study. Here you could nicely see the components of the circle of Willis, and usually when we do the study we look for filling defects. A filling defect in such a vessel may represent a thrombus, embolus, or even a dissection. The teaching point to emphasize here is that if you're only looking for filling defects, in some cases you could miss important findings. And this is a good case to emphasize that teaching point. Although you don't have a central filling defect, the vessels are abnormal. The vessels should have a smooth border without wall irregularity, especially in the absence of atherosclerosis. Knowing that, let's look at the right MCA here. You'll notice that the lumen does not maintain a normal caliber, it changes. And you'll notice that the vessel has this beaded appearance. This is also the case in the left MCA. It's also the case with the anterior communicating artery and part of the anterior cerebral artery. And now that you're looking at it, you'll see it in every other vessel, such as the PCA. And even here in the basilar artery, if you follow the basilar artery, you'll notice how the lumen changes in caliber and then goes back to a larger caliber. And here's a coronal representation of that vessel as it narrows and then goes back to normal. So this is the basilar artery. And remember, we're seeing this diffuse beaded appearance in a patient who does not have calcified or non-calcified atherosclerosis. Such an appearance is consistent with the diagnosis of vasculitis. The patient's labs did not show any features to go with an infection, and the patient went to have an LP with CSF analysis. So the lumbar puncture showed an inflammatory picture that is consistent with vasculitis. Subsequently, the patient was treated with steroids and showed improvement. So seniors, what have we learned from this case? The first thing is that restricted diffusion is commonly, but not always, due to your typical infarcts. And if you have infarctions that are distributed in multiple vascular locations, think about a cardioembolic stroke. If a cardioembolic stroke is excluded, think about other possibilities, one of which should include vasculitis. Vasculitis could be primary or secondary, confined to the brain or involving other organs, and that's a different discussion. Remember that involvement of multiple vascular areas in cortical and immediate subcortical locations suggests vasculitis as well. When you look at the vessels, whether it's a CT angiogram or an MR angiogram, don't only look for filling defects. Make sure to assess the luminal diameter and the wall smoothness as well. If you have a beaded appearance, especially if diffuse, and especially in the absence of atherosclerosis, think about vasculitis. That's it for today's case. Thanks for watching. Your comments are appreciated as usual, and see you with more cases later.